of this event. For your information, we've been ably assisted in outreach to the community by our Democrat Club counterparts. After we recently provided them a full briefing on the form and font content of the forum. I'm sure you appreciated the refreshments. They are provided by Erie Gold and Silver, which is a firm that provides investment grade gold and silver and gold coins. So they had business cards at the back, and if you have an interest in that, I suggest you grab one of their business cards. Now, let me say a couple things about the Republican Club. Our club, like all political clubs, provides an environment where people can get together who are like-minded and talk about politics. We conduct monthly meetings with candidates, legislators, and issue experts, speakers. And we publish a regular fact-based newsletter. The newsletter focuses on light, not heat, information, not inflammation. And it's distributed to roughly 500 people within the community, as well as a network of politicals outside the community, to the press. And obviously we're connected to our own campaigns, organizations. And of course, like any political club, at times we get involved with supporting our candidates for election. That's really not a large part of our activity. It just happens like right now. So, let me see, let's give you a feel of where this topic came from and how it evolved. Late last year at our club, we decided, what should we do different in 2014? And we decided to bifurcate our focus into, the regular speakers and to focus on an issue of relevance to our entire community. And of course, the Affordable Care Act is fairly controversial, but what is even more important to us as neighbors is what's that going to do to our Medicare. And so we decided to be focused specifically on the Affordable Care Act as it relates to Medicare and how it will change the delivery of our Medicare. So we had several presentations by experts from within our neighborhood. We have a lot of very talented people here. So we had a different perspective by each presenter. So we had a presentation on the legislative perspective, on the economic perspective, particularly the long-term economic impacts, a presentation on the general practitioner perspective, a doctor's perspective, and a presentation from an insurance broker's perspective, to give us some knowledge about, although it doesn't really relate to us, what are the policies available through the Affordable Care Act. All along, our focus has been on what is, not what ought to be. There's a big distinction there. And we want to know, factually, how our Medicare program will be affected by the market responses to both the legislation and the pending surge of baby boomers coming at us, starting right about now. They were born started officially in 1949. This is 65 years later. Right now is when the surge starts to ramp up in terms of loading the Medicare program. So far, we believe we just surfaced the tip of the iceberg in terms of what's happening, and we think there's much more understanding to be developed, particularly as relates to the social dynamic of this surge of baby boomers retiring, as well as the technological dynamic, which will ultimately be the market response to this huge demand. Markets always respond to opportunity. And so there's going to be a huge demand for technologies and when it comes to the changed delivery of our healthcare. That being said, we approach the community management with our findings to date and our intention to put together an educational forum for our community, and they've been extremely supportive. Now, there are probably about 200 people in attendance today from across the political spectrum, and that speaks to the relevance of the topic to each of you. Now, I'm going to introduce Mark Hopkins now. Mark Hopkins has been our project manager for this issue focus and has personally organized today's forum. He has a master's degree in chemical engineering and spent 35 years with Chevron Research. For those of you who don't know, he's one of our neighbors. He worked for Chevron Research in his career for 35 years. And he worked 10 years doing feasibility analysis of various energy-related technologies. He then represented his firm for about 10 years in interaction with regulatory agencies vis-a-vis those technologies. And for the past 15 years, he's been in Washington as a lobbyist for Chevron, advocating for their positions. Mark's a great example of the diversity of experience and abilities that we have throughout our community. And we're fortunate to have him here today to provide the legislative overview.
Okay, thank you, Marty, for that introduction. And thank you all for coming here this morning and sharing your time with us to learn more about the Affordable Care Act and Medicare and their interactions. I hope that you will find your time well spent this morning. We've got a great group of expert panelists to share their perspectives on the Affordable Care Act and Medicare with you this morning. About 94% of the U.S. population over 65 years old receives Medicare services. So I expect that virtually all of us today are either receiving Medicare or are certainly looking forward to and anticipating when we will be joining Medicare. And it's very obvious that the future of Medicare is of great interest to our community here at Anthem Ranch. And my task this morning is to give you some information about the Affordable Care Act legislation, or Obamacare as it's more commonly known, and discuss briefly how this legislation changed Medicare. My goal is one, to let you know that Medicare was a big part of the Affordable Care Act. And two, our panel members that we have here today represent what were really the biggest ticket item impacts on how the legislation affects Medicare and medical services more generally. So we think we have the right folks here to hit the right big ticket subjects, big subjects, and we'll be sharing that with you. Okay, the first slide, Marty. There it is. Okay, what I want to do first is just share with you a little bit about the Affordable Care Act and a little bit about Medicare to set the stage later for our panelists. The Affordable Care Act was signed by President Obama into law in March of 2010. So it's been around now for about 4.5 years. And we're starting to see now, over the last few years, quite a bit of the implementation of that and how it's affecting not only its marquee issue, which is extending health insurance to people previously uninsured, but its impacts on Medicare as well, and medical services more generally. The major features of the Affordable Care Act are as I mentioned just a moment ago, the extension of health insurance to those previously uninsured. And it does that in two ways, through the health exchanges that were rolled out late last year, and which have been highly debated and really not going to talk about here in our forum. We're going to focus on Medicare. Also through expanded eligibility for Medicaid. It also created new taxes to help finance that expansion of health care insurance. And we'll talk again, not a lot about the taxes other than the budgetary impacts, which I'll show shortly. And then the focus of today is that the bill, and Medicare was a part of it, this is the Medicare part, reduced the growth, or was designed to reduce the growth of federal Medicare payment rates to certain Medicare service providers. And in particular, the largest impacts were on hospitals, so-called Part A, part of the Part A providers, and also on the Medicare Advantage program, part of the Part C program. And that's what we're going to be focusing on today. And also particularly on doctors as well, not necessarily from a budgetary standpoint, but from a way the doctors, who are the gatekeepers to the medical services system, their lives have been changed quite a bit in the last few years. So that's why we have a panel consisting of doctor, hospital, and insurance. The next slide shows how the Affordable Act was scored by the Congressional Budget Office. And the Congressional Budget Office scores all federal legislation of major impacts, and what they project the impacts will be on the federal budget, on federal revenues such as taxes, on federal spending, on changes in federal spending over the next 10-year period. So you're going to see what this will represent are changes in federal revenues and federal spending over the next 10 years as a result of the legislation as calculated by the Congressional Budget Office, the official scorekeeper. And what you have are deficit raisers, or things where the federal government is going to be spending money, and is spending money, and that is the programs I mentioned with regard to the health care exchanges and the Medicare expansion. That new spending by the federal government is offset by two parts, and the part that I just talked about is in the green, the big bar in the green, just under $2 trillion. That's offset by things that will reduce federal spending or bring in new revenues. The first thing that will bring in new revenues is there's a whole series of taxes that are coming into effect right now on various activities such as medical device manufacturing and such. And that offsets a large part of that additional spending. So offsets about $1.2 trillion over the next 10 years of the $1.8 trillion that is the cost of the new programs. The other piece, and the piece we're going to talk about today, is the reduction in Medicare payments to providers that are projected as a result of changes in the law by CBO. And that comes into a little over $700 billion over the next 10 years. And when you add up the new taxes and the Medicare spending reductions, they basically offset the cost of the new programs. So that when you add it all up, and this is what legislation does, they package all these things together, determine what is the impact on the budget. The impact was basically budget neutral to slightly budget positive. You add up the new spending, new revenues, spending reductions, and you come up with actually the federal budget deficit would go down by about $100 billion over that 10-year period. So that's the results, and that's how they all put together. So that just talks about Medicare from a budgetary standpoint and how it's part of the legislation. Now the next slide shows big ticket items in those changes in the way the federal government payments go to Medicare providers. And the two big ticket items we're talking about today are hospital services and Medicare Advantage programs. And those represent roughly a little over 50% of the total change in federal spending over the next 10 years. And it's not surprising when you look at the slide, which I neglected to go over too much as carefully, the spending on Medicare. Those two particular activities represent about 50%, a little over 50% of current Medicare spending. So it's not surprising that they will be taking the brunt, if you will, of changes in Medicare spending reductions. Hospital services represent roughly a third of all Medicare spending by the federal government, and the Medicare Advantage programs represent about 25% of all spending, about a quarter, and if you add those two up, you get a little over 50%. So they're big items. And another statistic you might want to keep in mind is the benefits that Medicare beneficiaries receive. It's about $12,000 a year, what they received in 2012. So it's big impact and big changes. Okay, how do the hospitals' payments change, and how does Medicare Advantage change? And that's shown in the next slide. This is the traditional Medicare model. You have your beneficiaries over here on the bottom left-hand side, and beneficiaries and patients, they go to their doctors, they go to hospitals, they receive services, they pay their deductibles. The hospitals and doctors are paid by the federal government under the Medicare program for the balance of the services. You also, in addition to paying your deductibles, you pay a Part B premium to the federal government. And then the funds, the Part B premiums go to the federal government, and then the Medicare fund, along with the Part B premiums, provide the funding for the hospitals and doctors that aren't made up by the deductibles in your insurance program under Medicare. The red circle with the dollar sign in it is what's changing. The federal government is changing the way, through a number of programs, which I know John Higgins from Good Stuff will be talking about briefly, in the way they provide their payments to hospital providers under Part A. Okay, Medicare Advantage. Medicare Advantage is an alternative to the traditional Medicare model in that the private sector, insurance companies and HMOs, such as Kaiser, a lot of folks here use Kaiser, they are providing the service model directly to the patients and the beneficiaries in lieu of the federal government. They go through a process where they bid with the federal government to take over the Part A and Part B parts of the program. And if they can show that they're cost effective in terms of operating those programs relative to the standards that the federal government has set out, they will basically then have to be a contract with the federal government where they'll receive money from the federal government to run the Part A and the Part B programs in lieu of the federal government. And then they often package other parts of Medicare, such as the prescription drug program, into their Medicare Advantage programs. So what you see, what the typical beneficiary sees is interactions with their Medicare Advantage provider, either Kaiser or an insurance company such as United Healthcare. They pay their premiums to them on a monthly basis. They go to the doctors and hospitals and prescription drug suppliers that are part of that network generally. They make their co-pays and deductibles. And in this case, the hospitals, doctors, and drug suppliers have contracts with those Medicare Advantage providers. And so they do the reimbursement process and that type of thing. And where the federal government comes in is within this red dot again of the dollars, the money that they're paying the Medicare Advantage providers to run that part of the program. And again, the Affordable Care Act revises the bidding process and the way the Medicare Advantage providers are compensated for running that particular part of the program. And we'll talk about that, but those two are the big changes, and they basically have to do with the way the federal government reimburses those folks, funds those folks for the services that they provide to the beneficiaries. Now, the big question, and so how will this change things? And that's really the last slide, which is how does the Affordable Care Act affect Medicare? And if you go to the Medicare.gov website, you can get basically the administration's position on that, the federal government's position on that, which is they list the top 5 things you need to know about Medicare and the Affordable Care Act if you have Medicare. And the first thing is the thing that really kind of summarizes everything below, which is your Medicare coverage is protected no matter how you get Medicare, whether through the original, what I call traditional Medicare model, or through a Medicare Advantage program. You'll still have the same benefits and security that you have now. And they listed a number of other less important aspects, not to you all necessarily, but for our discussion purposes today, that are as well. Now, the concern that I have, and wanted to share with you, is that the federal government can control the reimbursement process, the contracting processes, and what they provide to the providers. That's under their control, and that's what the law changes. But what they can't control is the way that these providers, the way hospitals, doctors, insurance companies, HMO organizations, how they respond to that change in the federal revenue stream for the programs that they're running. And that is why we have our panel today. These folks are the ones who are dealing with that in real world terms, and that's what we'd like to have them share their perspectives about how they see what's going on today and what their projections are in the future. So, without too much further ado, I have a couple of more things to add. I want to talk a bit about the question and answer session. During the question and answer session, you all have question cards on your chairs. Circle which panelist you'd like to have, or more than one panelist you'd like to address your question. Write your question down while the panelist is talking, while the panel's talking. After each panelist gives their talk, I'll briefly go down the rows and take your questions and put them to the end of each row. Just hand them to your neighbor, get them to the end of the row, and I'll make a quick pass as we're going through the panel to collect all the questions. That's the process. When the panelists have all completed their remarks, we're going to have a short break because we have to do some rearrangement of furniture and such up here to get the panel discussions set up once we no longer have the screen here. And so we'll get ready for the question and answer session. And during the question and answer session, we're going to use the questions that you all have asked, get to them as many as we humanly possible can do. And Steve House, who is our moderator, I'll introduce just in a second, will be running that part of the panel discussion. And we'll have them address as many questions as we can get to. Also, you'll notice we're videotaping today's forum. And we hope to be able to send out some information following the forum that basically talks about what we've learned from the event and that type of thing. And if you're not on the Republican Club email list and don't receive information from us regularly and would like to receive the information that we develop as part of this forum, please on the way out at the registration desk give your email to folks, and then we will be able to send you the information that we develop. Also, we have a few more extra refreshments. So during the break that we'll have, the short break, you feel free to get up, stretch your legs, and have a little more food. So with no further ado, let me introduce our moderator for today, Steve House. He has a 30-year career in healthcare, including global service management, sales, marketing, executive management, and consulting roles for companies such as Philips, GE, and most recently Aetna. His work with Aetna includes using new technology to support new risk models in healthcare, such as accountable care organizations. He currently works as a consultant, working on grants and structural changes for Colorado's Health Policy and Finance Division. He believes that healthcare can have a prosperous and financially sound future if the right changes are made. Without further ado, it's my great pleasure to introduce our moderator today, Steve House.
Welcome to the forum. And by the way, I think we have a really great opportunity. Mark and Marty sort of alluded to who the panelists are, but let me really tell you who they are. We've got an insurance expert who you can complain to, yell at, or ask any kind of questions for. We've got a doctor, but he's not just a doctor, he's actually an entrepreneur, so he's got a lot of free market sort of ideas, which I'm very optimistic about in terms of how we go forward with healthcare. And then we got a hospital CFO who, if you got a bill outstanding, maybe you should talk to him after the forum. So we got a great opportunity this morning. And by the way, the fourth member of the panel, myself, most people refer to me as I kind of call myself a futurist, but that really means I'm just a techie nerd. So I love technology, and if you want to ask about technology, we can talk about that as well. I think it's important that we start out, though, with a statement that we've all sort of agreed to, and that is this will not be partisan. This will be a discussion about the law and its effects on Medicare, as well as some concepts and free market things that are happening. I think one of the reasons why I'm optimistic about where we are right now is because we're starting to see the markets react to Obamacare with new solutions. And I think that's very, very important. There are some things that I would be concerned about just from a factual perspective. I'm 12 years away from Medicare. Actually, my wife would say 11 years and a month, because I'm getting close to that next birthday. But I'm not that far away from Medicare myself. My mother's 73 years old, and she's on Medicare. So we have an acute understanding of what's going on, and my time in healthcare has also delivered that. I think it's important to know that my comments today, and I'm sure their comments as well, are going to be based on what's really going on with the law, and we're going to try very hard not to be biased in any way. My concerns start with this. You saw some of the numbers, and the CBO changes those numbers a fair amount. I mean, you could find numbers today that say Medicare is only going to be cut $716 billion, for example, and that the taxes are going to only add up to $550 billion. As opposed to $1.2 trillion. I think those numbers matter, but until we see more of this law implemented, we're not really going to know exactly what's going to happen. But here's some of the things. When you look at the Medicare.gov website, there were 5 things on there. I think 4 of them I have suspicions about. I'm not going to give you the details on those 4. You'll get those as we go along today. But I do have concerns about preventative services for Medicare recipients. There's a governing body called the U.S. Board of Preventative Services. They recently restructured what they thought was right for mammography for women between 40 and 49 and over 75. That governing body will decide what preventative services ultimately go into Medicare. So that's an important aspect of what's going on. The other piece of this is there's a board that's going to be formed by 2017 that a lot of people are worried about, and we're more than willing to talk about it today. It's called the Independent Payment Advisory Board. It's a 15-member panel appointed by the president prior to January 1st on 2017, and their job is to decide what reimbursement should be for Medicare procedures and who should receive that. A lot of people get really concerned about that, and so do I, but I'm not going to get too concerned just yet because we don't exactly know what's going to happen. Now, even though there are some things that I'm concerned about, I'm also very optimistic. The next 15 years, we're going to see technology changes in healthcare that we have never seen before, and they really, in my mind, have the potential to take care of healthcare's cost problem in a big way. You'll be able to wear sensors, you'll be able to have things at home that help monitor what's going on in your health. People ask me to simplify it, and I would suggest to you it's like an early warning system for tornadoes. Before you have a heart attack, we're probably going to know it in the not too distant future. Before you have a stroke, there'll be ways to help deal with that in the process. And I think all of those things are really, really important as we move forward. The question is going to be, how do we make sure we can innovate in an era where Medicare's cost structure is a big concern for all of us? It takes up a big part of the budget. How do we make sure we can still innovate? I don't think the free market will let us not innovate. I think when you see the release of the new iPhone 6 and there's a watch, you're all going to wear the watch, whether you're 75 or 95, because the watch is going to aggregate data on what's going in your body, and it's going to send it off to people like John in the hospitals at Good Sam, and they're going to figure out what's wrong with you before you know it. And that's not going to happen tomorrow, but I certainly think it will happen in a lot of people's lifetimes. So the other thing that I wanted to address is there's a rumor, or a myth, I guess is what I would call it, that once you reach 75 years of age, that you start to really accumulate a lot of healthcare costs. But you know what? The bulk of seniors who are mobile, who are active, actually after 75, your average cost of healthcare doesn't really vary much whether you live 1 year or 20 years. And I think if you're a senior today, you need to fight back with that. You need to say, hey, look, wait a minute. I still want knee replacements, hip replacements, bypasses. I want angioplasty, and I want cataract surgery. Those 5 procedures were the greatest mobility and life-enhancing procedures introduced in the last 4 decades for seniors. We have to make sure those stay, and that there isn't myths about what you can do when you're I call it an all-go senior, and my mother's very much like that. I wish she'd get off her bike and stop riding 30 miles because I'm afraid she's going to fall down at some point. But the reality of it is we have that ability. I think the other thing we have to deal with is we have to make sure that we continue to have the benefits of chemotherapy. I would fight for that if I was lobbying, because I think all of those things are what make life possible. And I think when you see studies, and there's a lot of really strange studies out there about how the cost structure is when you're older, but also the fact that you could have a reduced set of services and still have the same outcome. Well, that particular study that I would quote out of Dartmouth only examines people who are already dead. And so I don't know that I want to base my outcome on already being dead in that regard. The reality of it is, I think we have a great opportunity to see the free market react and provide things like new opportunities in membership type care and other things that are going to go on. And I think the other thing you're going to see, and John's probably going to be more aware of this than any of us, is I think we're going to see healthcare go global. I think people are going to start being able to get services in other countries that they can't get here, and that we're going to see people start to get really global in healthcare, and I think that's important. So take advantage of today. I'd love to have a great discussion. Ask the tough questions. We will try not to filter you unless you get too partisan on us, and then we may have to. But the reality of it is we've got a great opportunity to find out more about healthcare today and about Medicare. I'm looking forward to it, and I think we should start with our first panel member. And that panel member would be Dr. Stanley Jack. I was joking around with him earlier and said that I should really start by Dr. Stanley Jack, son of Donna Jack, because she happens to be his mother and she's here today. Dr. Jack, his family moved to Colorado in 1988 after receiving a BS in biology and a BA in psychology at the University of Colorado at Denver. Dr. Jack attended medical school at Des Moines University College of Osteopathic Medicine and Surgery, during which he did a year of clerkships at the Cleveland Clinic Health System. He then completed an internship in internal medicine and his residency in family medicine at Exempla St. Joseph's Hospital in Denver. Dr. Jack owns Boulder Valley Family Practice and recently opened a concierge medical practice called Broomfield Direct Patient Care. I know him to be incredibly bright. Let's hear from Dr. Stanley Jack.
Well, I'd like to thank everyone for being here today, and thank you, Steve, for the introduction. So whether you are currently paying into or have paid into or are about to become a beneficiary of Medicare, this is the changes to the Affordable Care Act made with Medicare should be of some concern to all of us. Oh, okay. Let's see if this stays up here. Let's see. Is this one? All right. So what is Medicare? And first of all, I just say that as organized as we appear up here, we actually did not get together ahead of time, so some of our presentations and content may overlap a little bit. But just real briefly, what is Medicare? Most people here understand what that is, what this is. But from the Medicare.gov site, Medicare is the federal health insurance program for people who are 65 or older, certain younger people with disabilities, and people with end-stage renal disease. so your renal transplant patients, people on dialysis. Briefly, Medicare Part A is your hospital care, Medicare Part B, outpatient doctor visits, Medicare Part C, those are your supplemental plans, your Medicare Advantage plans, and Medicare Part D, your prescription drug coverage. So Americans like Medicare. Patients like it. You have very comprehensive coverage. Most doctors take Medicare. There's about 90% of physicians still take Medicare, and very few have opted out. And about 2/3 of physicians are still taking new Medicare patients. Physicians in hospitals like Medicare because you get paid, and you get paid fairly quickly, and it's guaranteed. A lot of times, if you're dealing with patients with private insurance, they may or may not have that insurance may not be active. Sometimes you have to fight a little bit more with the insurance companies, but Medicare pays fairly promptly. And society as a whole likes it because it's a great safety net. Now, there actually were other plans in place before Medicare. I don't want to get too much into that, but there was Kerr Hills that covered 77% of seniors before this was passed for medical assistance. And there was the Hill-Burton Act, which provided free hospital care. Hospitals did this in exchange for grants and loans and things like that. So, but it's a very broad safety net, and eventually, if we live that long, we all get to participate. So, what is the impact of the Affordable Care Act on Medicare? And one of the figures that's brought up, Steve mentioned a larger number, so there's a number of numbers that are kind of bandied about, but this is one that the CBO came up with back in July of 2012. When there was some discussion of potentially repealing the Affordable Care Act, they asked the CBO to score and see what kind of savings then this would actually represent for Medicare. And the number they come up with at the time was $716 billion. Well, it's a little bit murky, as we've already kind of talked about. The numbers kind of change. Some would say that this is not technically a cut, but rather a reduction in the rate of growth of Medicare spending. However, you have to keep in mind that this is money that would have been spent on Medicare. Instead, it's going to be spent on the Affordable Care Act, on implementing the healthcare exchanges, on subsidizing the Medicaid expansion in the states, and so forth. So, since the money won't be spent on Medicare, the government now considers this a savings, and it allows the trustees to basically say that it has extended the life of Medicare. So, this is a little bit like if I went to my wife and I said, look, I want to buy a boat. It's $30,000, and my wife says, okay, you can spend $30,000 on the boat. Well, on the way to the boat dealership, I stop by the RV dealership, and I see a camper. And the camper's $30,000, and I think, well, that'd be kind of nice for camping and hunting and that kind of thing, and I spend my $30,000 on the camper. Well, I technically didn't spend any of my money on a boat, so I still have $30,000 to spend on the boat, right? Anyway, so Medicare cuts will tend to decrease access and increase costs, and that just makes sense. If you cut a program, you're gonna run into these things. They did the Heritage Foundation did an analysis about a year or so ago. About 15% of hospitals and nursing homes, home health agencies would actually become unprofitable within a few years. And the American Action Forum did an analysis that concluded that Medicare Advantage, the supplemental plans, the cost would actually increase by about $1,500 going from 2014 to 2015. Now, something kind of interesting happened in April, and that was for the second year in a row, the administration delayed cuts to these programs. In fact, not only did they not cut them, but both years they actually increased them. So you can see what I mean by a bit of a moving target. One of the other things that catches my eye as a physician is this thing called readmissions. Under Section 3025 of the Affordable Care Act, and John and others, Michael will talk a little bit about this. If now face penalties for readmitting patients with heart attacks, congestive heart failure, pneumonia within 30 days of discharge. So, for example, if a patient has been seen and treated for a myocardial infarction, maybe they've received a stent, and then they've been discharged. If they come back within 30 days, there is actually an incentive a disincentive, I should say, to admit that patient too readily. Now that's kind of an interesting concept to wrap your mind around. Now, granted, if you're an ER physician and you see somebody coming in that hey, I just saw you, how's the heart? Oh, you know what, you're going to stay here tonight. They don't technically they use something called observation status. And what observation status is, and I'll get this into this a little bit more in a further slide, is it's basically a technicality, so they're not technically readmitting you. So, kind of stepping back, if we are to disincentivize or to put penalties on hospitals for readmitting some of our sickest patients, what happens to outcomes? Well, for one thing, the goal is that, I should back up and say, the goal is to make care more efficient and make physicians more proactive about preventive care. Do it right the first time and you won't have to readmit the patient. Sometimes things don't go according to plan. There's already been a drop in readmissions of about 1% from 2012 to 2013, which obviously represents a cost savings in terms of dollars. Yet, if you look at America's top hospitals, their readmission rates are actually a little higher. Now, I don't know how much you can read into that, but it's of note. And then they did a California study of many hospitals showed that Medicare patients that were treated at the lower spending hospitals, because this was the goal, is that you spend less at the hospitals, actually had less desirable outcomes. Now, whether that's cause and effect or just correlation, we don't know, but it is of note. So back to observation status. So let's say you go in and your risk of having a heart attack after having just had a heart attack or some other fatal arrhythmia or potentially fatal arrhythmia is fairly high within the first 30 days. They're going to have you stay in the hospital. They're not going to send you home. But the way that they get around the readmission penalty is they put you on observation status. This basically allows the hospital to treat you. And for all intents and purposes, it's this exact same treatment. You go in, if you need to be admitted to the coronary care unit, you're there. If you need some kind of percutaneous intervention, the cardiologist will provide that. But when you get the bill, instead of Medicare picking up the entire tab, you may be responsible for about 20% of those costs. So just something to keep in mind. Now, it's not all bad news. In fact, in my setting, the primary care setting, we mentioned Part A is hospital, Part B is outpatient, Part C is Medicare kind of Advantage plans. I'm not directly affected right away, although indirectly through the Medicare Advantage plans, our practice and our patients are affected in the outpatient setting. But for the most part, it's been all upside. Free physicals. This used to be a problem. A patient would come in, we'd have to code it under hypertension or high cholesterol or something, but if you had a very healthy 65 or 68-year-old, it was sometimes difficult to find code and do blood work. But now all that stuff is covered. Free mammograms, free colonoscopies, no co-pays. And there's prescription savings now too. You've probably heard of the so-called donut hole. This is going to be phased out now with regards to prescription drug coverage by about 2020. And about 50% of your trade name medications are going to be covered. So what are the downsides? Just to review, for one thing, the cuts are going to put some providers and hospitals out of business. You may find, because as Steve was alluding to, doctors respond. We can get those pesky doctors just to behave. Sometimes what they'll do is they'll say, you know what, I'm going to adapt to this. I need to be able to continue my, to pay for my overhead. And I should say, and we're not necessarily a terribly sympathetic group. Most people think that doctors make a lot of money, but we're making about half. We see about twice as many patients now as we did in the 1970s, and we actually make less in inflation-adjusted dollars. So there's going to be a limit at how much you can cut physician reimbursement before they say, look, we've got to react to this. I'd say that you're going to see more probably opt out, although time will tell, because we don't know what cuts are actually going to be implemented. And then I put a couple of other things there with question marks, the accountable care organizations. Steve will talk a bit more about this, but think of these as your modern day equivalent to an HMO. And there's a lot of incentive to keep patients healthy, to be very proactive, to do a lot of preventive care, to be very sophisticated about your treatments, maybe have you wear a monitor, and those types of things to stay on top of things. But bottom line, as opposed to, say, the fee-for-service system where maybe the doctor actually gets paid more for the more care that they deliver, you actually are incentivized to provide less care. So just kind of keep that in mind. Big data, this can be a good thing for epidemiologic studies, for kind of finding out what your efficiencies and deficiencies are. But you talk to some of my libertarian friends and they say, okay, it's fine if they want to track blood pressure and cholesterol and those types of things. But what if they start, making inquiries as to, okay, I'm a smoker, but now what about, do I have a gun in the home? What are my sexual preferences? What's my party affiliation? Is that all going to eventually happen or not? So they're a little nervous about big data. Sustainable. This is kind of a question mark too. Well, not in my mind. It's a matter. It's not sustainable long term, and I don't think you'll find any government agency that will tell you it's sustainable long term. And this term of insolvency, it's been moved out about 15 years. The ACA allowed government to extend that another 13 years, I believe. Insolvency doesn't mean it's bankrupt, it's out of money. It just means that the payroll taxes with regards to Part A, you're not collecting enough to pay 100%. So maybe now you've got enough to pay 90%, 80%, and so forth. So some of the more confounding factors with regards to trying to figure out the budgets, there's something called the SGR, or the Sustainable Growth Rate. I've heard also referred to as the doc fix. These are planned cuts that they started back in 1997 when they said, okay, long-term Medicare is not going to be solvent, so we need to start cutting costs. And we're going to reduce by a certain percent every year physician and hospital reimbursement. Well, of course, physician groups and hospital groups and patient advocacy groups got together and said, no, this is going to limit care because people are going to react to that. You're going to put hospitals and doctors out of business. And so that can has been kicked down the road many times. The cuts are now up to 24%. If that was ever implemented, you'd literally crash the system. So it's never going to happen. But this is something when they're calculating budgets, they always assume that it's been done or will be done. We also mentioned briefly the Independent Payment Advisory Board. This is a quote from Donald Palmisano, he's the former American Medical Association president. And just inject a little bit of controversy here. These are this is what Sarah Palin called the death panels, okay? So his quote was, the 15 officials who will make up the board will not only be empowered to make what is expected to be billions of dollars worth of cuts to Medicare every year, but will be required to do so when spending exceeds targeted rates, which of course spending always exceeds targeted rates. So the thing that's kind of significant about this is this is an unelected panel. They have more power than Congress. They can only be overridden by Congress with a supermajority, and Congress would still have to come up with those cuts. They just have to cut them somewhere else. I know this is about Medicare, but just really briefly, what about everyone else? So, like I say, things are looking pretty good for my Medicare patients presently. Premiums are going to go up for my private health insurance clients about 49%. Deductibles are going through the roof. We're looking at deductibles now of $6,000 or $12,700 for families. You don't necessarily get to keep your doctor or the plan you liked. I've had patients literally put into the Medicaid system. I don't take Medicaid, so they can't see me anymore. And is actually our clinic lost its insurance, and we were happy with it. But we found another plan, and actually it wasn't that much more expensive. So we're doing okay. And when all is said and done, the CBO, the Congressional Budget Office, says we will still have 30 million Americans uninsured once the ACA is fully in place. How am I doing on time? I'm over. Okay. Okay. Well, let me just close with this thing. So big government, I would just say that we have to be careful. I personally believe we're kind of moving in the wrong direction. I'm not a big advocate of insurance because there's a lot of bureaucracy there. I think it removes the doctor and patient from each other making those medical decisions. Someone else is now more involved. big government kind of exacerbates that. There's 159 regulatory agencies that are come with the Affordable Care Act. The federal government tends to focus less on customer service. They're kind of more running the numbers. You should also keep in mind that the federal government has the power to make you buy a product you may not want. And it's not necessarily good for competition either, because they're not just another player, they're not just the referee, they also make the rules and they enforce the rules. And so we kind of keep that in mind, because we saw what happened with the VA recently. Can we trust an increasingly centralized government to responsibly manage our health care and not abuse its power? Now later on we can kind of talk about things that we can still do that will actually empower patients and doctors, but I'm over time, so I'm going to try to respect that. Thank you.
So before I bring up John, just two quick things about what Stan said. One is, I think it's really, really important that you know when you're paying or when the reimbursement's been made by part